I'm just thinking back to many years ago when HIV came to the scene and we started to segregate our instruments and started to believe that standard precautions weren't sufficient. And do we have to double clean these scopes? Do we have to send them down to be sterilized after a COVID patient? And just to relieve those fears that they stick to policy, they stick to procedure, then they're producing a patient-ready endoscope.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Jim Collins, endoscopy accreditation and quality assured nurse for the Cleveland Clinic. Jim is quite active with SGNA on both the regional and national level, earning the Distinguished Service Award in 2017. He is also a member of the ASGE's Practice and Operations Committee and actively participates in additional quality initiatives. Larry, Jim is a colleague of yours. The two of you have known each other's work for many years. He's very gracious to join us today, but also was actively involved in the development of the new multi-society guidelines. And we're going to narrow this conversation down a little bit. We've talked about endoscope reprocessing and the guidelines, but we're going to drill down in a little bit tighter detail and also from a frontline end user's perspective, what the last 13 months have been like. So this is going to be very insightful. And I think everybody listening, whether you work in a GI lab or you have a broader responsibility in infection control, that there's going to be a lot you're going to be able to take away from the conversation today.
And I think what our listeners will appreciate in the podcast in general and our discussions with Jim is that these topics that we're discussing are really insightful and educational. And I would encourage the listeners to subscribe to and listen to as many of our podcasts as possible, because we are getting into detail that typically will not be heard anywhere else. So I'm really appreciated talking with Jim. I have appreciated talking to all of our guests, and I learned something every time we talk to them.
All right, we're going to be right back with Jim Collins after a short break.
Brought to you by 17 Studios. Let's get into it. This is Transmission Control.
Joining us now is Jim Collins, endoscopy accreditation and quality assured nurse for the Cleveland Clinic. And Jim, we're quite honored to have you as a guest today. And I know we're going to be talking about a couple of things. One, the impact of the pandemic on endoscope reprocessing in GI. And then we're also going to take a little bit deeper of a dive on the multi-society guidelines. We did an interview recently with Dr. Muthusamy, but we brought you on to speak more specifically around some of the guidelines specific to population-based practices and facility risk assessments. So thank you so much for coming on today.
Oh, it's a pleasure to be here, Justin, and always a pleasure to have the opportunity to speak with a dear colleague, Dr. Larry.
Yeah, you and Larry know each other, and as you mentioned, are colleagues. I'm not sure. Have the two of you ever had a chance to meet in person?
Oh, yes.
Yeah, many times through the years, right, Jim?
Yes.
Many times, going back about a quarter of a century, I guess.
Yeah, I believe so. Yes.
Well, I know both of you have quite a bit of knowledge on this subject, but before we get into the multi-society guidelines, let's talk about just how everything has been so different over the last year for you, Jim, and your department, and really everybody across the country in GI, because I know with the pandemic, one of the biggest things that I heard a lot of reprocessors in general asking questions about was aerosols and the aerosolization potential of the virus and how that relates to transmission. And especially when you're talking about scopes that are used for intubation on COVID positive patients. So can you just kind of talk about what life has been like for you over the last year? Because so many things were brand new and the conversation's so different than maybe the traditional day to day that we had all been in prior to about 13 months ago.
Yeah, that's a very good lead-off question that we could talk quite a while about. But when COVID hit about a year ago, that we were very concerned about the spread of the infection and the aerosolization and the droplets and the mechanism which this disease was spread. And we had to really examine those aerosol-generating procedures and where they were in our department, as well as the institution, everywhere from visiting the dental services at the facility to the intubation of patients for general anesthesia, as well as for GI endoscopy and bronchoscopy. It really put us on secure mode to heighten our awareness of proper PPE that was being utilized for our procedures now, as well as assuring that the correct PPE was being worn as well, and then monitoring even our caregivers up on the units to ensure that universal pandemic precautions were being utilized as well throughout this period.
I'm sure you were really leaning towards that conversation about the N95 masks and whether they should be worn. But I wanted to ask you another question before you maybe provide more detail in that regard. Did you find that infection control nurses and team members were more involved with you and your department? I mean, I'm sure there's always some level of involvement, but in many cases, they are very global to the entire institution. Did you find that you had more interaction with infection control during this period?
Well, I think it was all hands on deck when it came to the situation, that we saw active engagement of infectious disease throughout the Institute, as well as our infection practitioners as well. And they have a very, very broad band to work with, from everywhere from GI endoscopy to, I said, taking care of the caregivers on the nursing units. So it did heighten their engagement with all folks throughout the facility, as well as spreading the word to units that remained open during the short time that we did have mandatory closures, that we saw a lot of people that were reassigned and to help in other capacities until their units were reactivated. So I think we did discover, too, that the crucial role that IP plays within the institution, and become to appreciate them more when questions arise to what sort of precautions had to and needed to be taken.
So, Jim, I wanted to follow up a little bit on the PPE and the kind of the N95 debate for the technicians. But before I do, if you had to single out one issue in terms of the management of GI endoscope reprocessing and how COVID changed that management and what was realigned in how you optimized your workflow and how you optimized endoscope reprocessing, you had staff maybe that were not as available to help out and to perform the necessary steps to reprocess the scopes. So what, for our listeners and for me, not knowing this as well, what really was probably the number one or number two issue that had to be optimized in terms of your management of the workflow in general, and specifically endoscope reprocessing? How did it change, if at all, as a result of the virus?
Well, as we know, that the COVID virus is easily killed by our traditional reprocessing means. So there weren't special processes or initiatives that had to be taken in our reprocessing of our instruments. I think what the heightened awareness came is to our reprocessing staff themselves, to ingrain into them the need for ensuring proper PPE is worn consistently throughout the process. And though there's no evidence to suggest that N95s assist or prevented our reprocessing staff from potential contamination, it was a prudent measure to do to make these devices available for reprocessing staff as well. And then it was to also I'm just thinking back to many years ago when HIV came to the scene and we started to segregate our instruments and started to believe that standard precautions weren't sufficient. And do we have to double clean these scopes? Do we have to send them down to be sterilized after a COVID patient? And just to relieve those fears that they stick to policy, they stick to procedure, then they're producing a patient-ready endoscope.
So we'll talk more about HIV. I think that's a very interesting parallel that will bring us into the discussion of standards of care and risk assessments that we can get into with our second topic that we wanted to get some insight from you as a result of in your work in the multi-society guideline. So with the COVID-19, though, in general, you can summarize for our listeners who might be thinking about undergoing a procedure that your clinic and others across the country have a handle on the COVID-19. They don't need to worry about anything in terms of COVID-19 transmission, that no new protocols are necessary, that the adopted standard of cleaning followed by high-level disinfection and drying, and we'll talk about all that in a second with the guidelines. But you have your staff protected, and for the patients listening, there's really nothing that needed to change. There's no reason why patients would need to be concerned at all about COVID-19 in terms of the practices that you're implementing in your unit. Is that correct? Is that fair to say?
Oh, that's more than fair to say, Dr. Larry. I think we know from the pandemic plunging along that there has been a sharp decrease in number of patients that are seeking health maintenance procedures, be it colonoscopy, mammography, or what be it. Patients are avoiding going to the ER when they believe they're suffering from stroke symptoms or from a heart ailment. And they need to rest assured that what we've been doing in our institutions, practicing universal pandemic protocols, has created a safe environment for the patient to seek these treatments, and that we know that exogenous infections do exist, but endoscope-associated infections through a contaminated COVID-19 endoscope is probably very unlikely to occur due to current reprocessing technologies.
So that's really great to hear, Jim, and I really appreciate your sharing that with the audience, because I think that's something that everyone has been a little concerned about, and I think you've allayed the concern. And you've talked about a couple things, as of course you must have been reading my mind, because you talked about the HIV issue. And one of the things we wanted to talk about in particular today, as far as the multi-society guideline, which of course is the 2021 updated guideline, originally written, I believe, 2011, and then revised in 2017, and now in 2021. I had a couple questions and wanted to get some insight from you on that. And let's use that HIV model that we talked about. The guideline starts to talk about the issue with sterilization of duodenoscopes as opposed to the endorsed process of high-level disinfection. And the guideline seems to take a little bit of a stance, and correct me if I'm wrong, but it suggests that maybe sterilization of duodenoscopes would be indicated, would be recommended, but for certain patient populations, so maybe an immunosuppressed patient population that we can get to a little bit in the discussion about the sterile water versus the tap water debate. But we always understood, and you and I have talked about this through the years, about the one standard of care. And if we adopt the paradigm that HIV was the standard, and we assumed everyone had HIV, then that almost lent me to conclude prior to reading the guideline that we really wouldn't be recommending anything based on a patient population per se, that we would treat the entire patient population the same. And I am seeing more reports and more draft guidelines starting to talk about this patient population issue. So can you talk about this and kind of clarify for me in my mind whether we're going backwards a little bit, or is it okay and acceptable now moving forward, and the consensus that we can have two standards, which I personally have some concerns about, but this issue of sterilization based on patient population as opposed to either sterilization for everyone or high-level disinfection for everyone. I said a lot there, but I'm really interested in hearing your thoughts on that.
Very good. I really think the multi-society paper first came out in 2003, their first rendition. I do think. But
thank you for that correction.
Yeah, it's a very interesting point. Population care and more or less selection of how we process an endoscope. We know that when we look at Spaulding's classification and the classification of medical instrumentation, sterilization is for the most part is optimal due to the fact it's the total elimination of microbiological presence. And endoscopes traditionally have been high-level disinfected just due to the fact that that was their construct. They weren't very amenable to sterilization technology. They can't undergo steam, and other than the presence of ethylene oxide used to sterilize endoscope, and now we're learning other technologies such as hydrogen peroxide plasma and maybe ozone technology, that these are making their way into the practice field. And then we have an introduction of single-use technology as well that maybe be considered, and I hear a lot of that when we talk about population-specific use of devices, that we have a large number of patients that present that are immune compromised, maybe liver transplant being a prime procedure, and they are undergoing an ERCP, and many of them have very many ERCPs that need to be done. And due to the fact that we have questions, and there have been outbreaks that occurred, that perhaps sterilization is maybe needed for these individuals, and that could help eliminate possible adverse events within this population and make a case for utilizing this technology. We know that we've tried to remedy the situation in other means through disposable end cap technology of duodenoscopes. We've tried to look at heightened awareness of doing 2 times high-level disinfection. We've looked at liquid chemical sterilization of endoscopes. Many of us have tried to do microbiological culturing of endoscopes to monitor the process. And we know that these can be time-consuming and problem-prone, and really evidence doesn't really lie on the fulcrum of which way we should go with these measures.
So this is excellent feedback. I think if I had my druthers, and you can correct me, I'd like to have an endoscope design that would be sufficient so that everyone could safely have a high-level disinfected scope. Or, if not, I think I would like everyone then to have a sterilized endoscope. I think we can get into this situation where we're evaluating the patients. It's very similar as we were talking about earlier about, well, does the patient have HIV or doesn't he? Should he then have a sterilized or not a sterilized? So I think these are really, really good questions that maybe we don't have the answer to yet. But I think it then leads us into the issue of the tap water versus the sterile water debate. In the 2011 guideline, we kind of had the issue where sterile water was recommended. Then in the 2017, we had sterile water was recommended. A little nuance in the 2021, no longer was sterile water in the irrigation bottle necessarily recommended as much as something that one could consider. So I'd like to tie things up soon with the 70% alcohol debate. But before we get to that, what are your thoughts about the sterile water versus the tap water? Is it something that maybe this sterile water should be recommended as opposed to just considered, or am I reading too much into the distinction between recommended and considered?
Yeah, I think that's been a head scratcher for a while, the use of sterile water during endoscopic procedures. And we circle back for looking at the MIFU from the endoscope manufacturers that more or less directed us to utilize a sterile water product. And there's been research done with sterile water, or if we just use a tap water, because the patient's been drinking tap water and it's going into the GI tract. So we're using an endoscope that's been properly processed. We're using backflow technology on our irrigation tubings. So where's the proof within that pudding that directs us for the need for the use of sterile water? And I think that's maybe an area that could be further researched, but with the number of procedures being done, and there are mixed practices about utilizing it, and it's all been based upon the MIFU of the scope manufacturer.
So I think that's an excellent point. And then we'll get to the alcohol rinse in a second. But when we say sterile versus tap water, are we talking about all GI procedures? Might we want to lean towards sterile for the ERCP in the washing the lens as opposed to irrigating in the colon? A few comments on that to clarify that distinction for me and our listening audience?
Oh, yes, that's an excellent point, is that we want to be very selective on if we're going to change our repertoire of irrigation solutions that are being used with high-risk procedures being performed in. I would say that the ERCP would be one of those procedures that fall into the different category that we'd want to maintain the use of sterile water. And also when we look at certain other high-risk procedures such as ESDs or other procedures that we are making intentional holes in the gut so we can do some work, that it would be prudent to use sterile water for these procedures as well.
So that's excellent, Jim, and I really appreciate that clarification, and I think listeners will really appreciate that and have some real solid information they can move forward with. So then that brings us to one of the topics I've been most interested in, and as you know, I've written about, published about a lot, and it has to do with the benefits or not of the alcohol rinse prior to the forced air at the end of the reprocessing step. Many of the procedures, as you and I know well, going back into the 80s, the 90s, the infections weren't from HIV per se. They weren't from hepatitis B. They were from gram-negative bacteria, typically those type of bacteria that like moist environments. So what did we say? Well, we said, how do we stop outbreaks? For example, when we look at the Alvarado paper in 1991 or the Allen paper in 1987, how did they stop these outbreaks in ERCP and upper GI procedures? They added an alcohol rinse, and they found, very similar to what we've recently found with bronchoscopes too, is the implementation of an ETO step, an ethylene oxide gas sterilization, abruptly terminated outbreaks. So we saw kind of this in the 2011 guideline that talked about it. We saw this in the 2017 version of the multi-society guideline. But when I read the 2021 guideline, I got a little confused. So I know this is on my end. I'm responsible for this. There's something I'm missing. But the guideline kind of talked about the alcohol flushing and the data supporting that as being very scarce. And I got confused with that, and I'm sure you can clarify it for me. But there seems to be data that supports that practice. And I know we get into the disinfecting issue versus the fixing protein issue versus evaporation issue. But can you give our listeners some insight into whether the alcohol rinse really is something that maybe we overshot on and isn't as important, or based on my research, I have found it to be fairly important, and I was just curious about the guideline stance on that. And maybe you can clarify that for me and the audience so that everyone's clear about whether they should or don't need to be doing the alcohol rinse.
Alcohol and forced air drying. We know that our endoscopes, as part of the process, need to be thoroughly dry. Not only on the exterior of the endoscope, but those interior channels as well must be drier. They become then prime environments for microbial growth. If we examine our MIFUs, the MIFUs direct us to flush the channels with alcohol. But interesting enough, when we look across to the European Society has included in their recommendations that alcohol doesn't need to be performed on reprocessing of endoscope, that forced air drying should be sufficient. Well, other professional organizations do reach out and stipulate the MIFU to be followed. So thorough drying of the endoscope is absolutely necessary, and we know that alcohol helps facilitate this. We can review papers from others interested in endoscope reprocessing that they have found residual alcohol in endoscopes after reprocessing. But these examinations, I don't think have been done after proper drying and forced air challenges of those channels to ensure that they are dry. And we need to have a Sahara Desert conditioned endoscope to say that reprocessing has been complete. So I'm still a fan of using alcohol as well as thoroughly drying that endoscope.
So Jim, thank you for that comment on the European guideline. I think that is correct. They do actually not contraindicate the alcohol rinse so much as simply saying they don't recommend it. And I think they focus on the protein fixative properties of alcohol, and I think that's something we should investigate more. I think we do have some data showing that the alcohol rinse certainly does reduce the risk of infection. I'd look forward to seeing some data that suggests that the alcohol rinse kind of in concert with and encountering protein in the internal lumens actually could pose an increased risk of infection to the European guidelines point. I have not seen those data in the last 30 years. but I'm very interested in following up on that, hearing other perspectives on that, and moving forward on that. So I think this has been an absolutely great conversation, Jim, and wanted to know if you had any more comments about some of the topics we've talked about, tying any loose ends.
No, I just like to express to our listeners that endoscope reprocessing is a consciousness, and that it is a process that needs to be thoroughly completed from step 1 to step 120. That there are no shortcuts, and each phase is just as important as the previous phase because they build upon one another to keep our patients safe.
And one of our other guests said, just like similar to the several steps for cleaning, that the several steps for drying, whether or not the alcohol is involved, is also something that maybe should be more validated than it has been in the past. That rather than simply saying dry the endoscope, we might have to look a little closer at the individual model, the individual
Correct.
type, and how exactly to dry it.
Yeah, the amount of pressure and the length of time and really studying that. Absolutely, Larry. I think that's a fantastic point.
Yeah, exactly. You can't, if I have a double channel colonoscope that I'm drying, it definitely will have a different need than that pediatric gastroscope that I'm utilizing that has very small channels that doesn't need the same amount of pressure or time to complete drying.
Another good point, specifications may dictate different parameters.
Yes, and it is even like each endoscope has its own drying profile. You had said earlier MIFUs, and just for our audience who might not know that, we all know that very well, but it's manufacturer's instructions for use vis-a-vis endoscope reprocessing.
Correct, yeah. MIFU, IFU, the same bear.
Very good, very good.
Jim, really nice job, and I appreciate all your contributions to the Multi-Society guidelines and then sharing your insights with us today. Keep up the great work.
Thank you for the opportunity again to participate in this program with you, and I look forward to enjoying additional presentations in the future.
That was Jim Collins, endoscopy accreditation and quality assure nurse for the Cleveland Clinic. And, there was something we touched on at the very end, Larry, and I want to thank you for making sure that we went into the acronym and defined it as the manufacturer's instructions for use. That's so critical. But there's an episode for us in here to really explain how the validation process goes, then the verification once the device is received from the facility, all based on those instructions for use. Because really the science that goes behind approving a device is really played out in the instructions for use, and it's the backbone for it. So maybe on another episode, we can bring somebody in to really connect all those dots for some end users. I know at the beginning of this conversation, I asked Jim about how does this all play into your engagement with infection control? Because I can only imagine their jobs got very difficult in the hospitals all across the country when the pandemic hit. But then especially in areas like this where they were considering process changes and how do they address things like aerosols, that they got very involved, maybe more so than normal with the GI labs and departments across the country. But I also like how Jim really sort of calmed any fears down and said, look, we've had standard precautions all this time, and standard precautions addresses killing viruses. And so those standard precautions didn't change. Nothing changed that way.
Right.
And we just have to make sure that everybody is maybe a little heightened and more aware because of the challenge of the pandemic. But we didn't have to rewrite the book on reprocessing, which is a huge takeaway from this interview.
Yeah, I think he gave us great insight on many topics, how COVID-19 has impacted endoscope reprocessing, workflow. It's something that has changed all of our lives, and certainly endoscope reprocessing was not exempt from that. I think he also gave a really good insight. I always like to talk to authors of guidelines to kind of understand all the factors that play in to the final result. And being an author of such an important guideline as that 2021, I think he gave us really good insight on the whole HIV debate going back many years, and how that may apply now to immunosuppressed patients in the context specifically of the single use versus the reusable, the sterile versus the high-level disinfected endoscope. I think these are all really good topics. And if anything, I think what I learned today is that not as much was resolved in our discussions as we learned how much more we still need to talk about these. And I also appreciated his comments on the 70% alcohol debate. But if anything, we also learned again that it's not resolved, that there's more research to be done, and that's a topic to be continued.
Yeah, and I will also say that Jim not only was a willing and gracious guest on this episode, but he wanted to make sure that all the listeners were able to get his contact information. So if you have questions about his involvement in the multi-society guidelines or
his practices at the Cleveland Clinic, one of the most renowned institutions in the world.
Absolutely. He wanted us to share that with you so that you can reach out to him. So email for Jim is collinj, so COLLINJ at ccf.org, and the CCF stands for Cleveland Clinic Foundation. And you can also call him by phone, 216-312-0739. And again, I just think that that's Jim making himself available as a resource. It's just such a fantastic thing.
And he may regret doing that because his phone may be ringing off the hook and the operators at the Cleveland Clinic may complain at him. But we thank him for doing that.
Yeah, definitely. Thank you, Jim. And let us know if it becomes too much. That's going to do it for this week's show. As a reminder, you can help support Transmission Control by subscribing on iTunes, Stitcher, Google Podcasts, Spotify, or your favorite podcast application. We'd certainly appreciate a rating and review because your feedback is important to Larry, myself, and the show. And on behalf of Larry and I, thank you for listening to this week's episode of Transmission Control.